Bundle branch blocks, bifascicular blocks, trifascicular blocks, hemi blocks. They're all high yield for your exams, but confuses most people. I'm going to teach you how to never forget them. First by understanding them and then locking them in with memory hacks. We're going to cover the fundamentals like normal cardiac conduction and what happens in each of these different patterns, as well as the specific ECG changes we see and importantly, why they even happen. By the end, they'll be unforgettable. By the way, if you're new here, my name's Matt. I'm a doctor who consistently ranked first in medical school, and now I help students and healthcare professionals study medicine smarter and remember more for longer. If you want to slice your revision sessions in half, then you may want to check out some free pages of my Never Forget study series. Links in the description. Let's get into it. First, we need a reminder of normal cardiac conduction. The circuitry is the superhighway for action potentials to quickly depolarize the entire myocardium. The impulse starts in the natural pacemaker, the sinoatrial node. A wave of depolarization spreads over both atria, but it cannot reach the ventricles. Instead, it has to activate the atrioventricular node, which in turn sends the signal down the His-Purkinje system. Importantly, the bundle of His breaks down into the different branches. We have the right bundle branch and the left bundle branch. Even more importantly, that left bundle branch is made up of a few different branches itself. The left anterior fasciculus, which goes to the upper and more lateral aspects of the heart, and the left posterior fasciculus, which goes to the lower and more posterior aspects. But there's also this little fella responsible for septal depolarization. I'll mention that one soon. Anyway, we've spoken about the so-called AV heart blocks before in another video, so you might want to check that one out. Those blocks tend to be at the level of the AV node, but we're more interested in the other branches being blocked this time. To diagnose them, you're going to need to spot them on an ECG. But first, quick reminder of what normal looks like. Firstly, the SA node fires, which causes atrial depolarization. We see that as a P wave. There's a time lag until that signal's picked up by the AV node. That delay is the PR interval. When activated, the AV node sends the action potential down the His-Purkinje system, which we see as a QRS complex. Then lastly, all of this resets to receive the next action potential called repolarization, and we see that as the T wave. I've been showing all of this on the second ECG lead, which is the lead most in keeping with the abnormal axis of the heart. But when it comes to bundle branch blocks, the ones we really want to be looking at is V1 and V6. V1 gives you that slightly right septal view of the heart, whereas V6 is looking more laterally. It helps us build a picture of the movement of current. Let's take a step back to when the AV node is activated. The signal arrives at the bundle of His. Now, the very first part which gets depolarized is actually the septum. Remember this little fella? Depolarization down this branch causes the septum to depolarize in the order of left to right. V1 is more looking on the right side. So the septal depolarization causes this little R wave in V1. As it's moving away from the V6 side, we may see a small Q wave, a negative deflection. The next bundle to fire is the left bundle branch. It dominates the ECG. Remember, that's going to be more on the left side, which is away from V1, so there's going to be quite a big downward deflection. Whereas in the V6 area is the opposite, there's going to be a great big R wave. And lastly is right ventricular depolarization, but it happens so quickly after the left side usually that we don't see any discernible difference. Okay, now you know what normal depolarization looks like on an ECG and how it looks in V1 and V6. So let's understand where the blocks can happen. It'll make it much easier to picture later. A branch block is when any of these wires don't conduct electricity normally. Here's a high-yield diagram. The bottom line is that any myocardium that isn't innervated is going to depolarize slower than usual, which you'll come to see. We can have blocks in a bunch of places, either the right bundle branch, the common left bundle branch, either of those two fascicles, which we call a hemiblock, or a combination of the two, which we call bifascicular and trifascicular block, which we'll go into later. But if it's all the way through here, we call it a complete heart block, which we spoke about in the AV heart block video. Let me show you that if we have a bundle branch block here, all of this part of the myocardium isn't going to depolarize as uniformly. To remember this, I want you to think of the superhighway. Imagine these wires are quick paths for the electrical conduction to get down to the ventricles. However, a bundle branch block is like closing one of those lanes. But luckily for us though, myocytes are pretty good at conducting electricity. Even though there's a closed lane, the electricity is still able to get from this left side over to the right side, but it has to do so through the back streets instead. It takes a longer route to get there, which is why we tend to have the spreading of the QRS. This underpins the reasons why we see these ECG changes that I'm about to show you. That covers all the fundamentals, which is going to make this next part even stickier. Okay, I want you to check out this ECG. In case you're coming back for your revision, I strongly recommend you do that. I want you to see if you already know what this is. I'll give you a few moments. Now your eyes should be going here. And there's a few abnormalities you can see. Get into the habit of casting your eyes over V1 and V6 and comparing them together. We can see there's some widening of the QRS, and there's a strange waveform in V1 and V6. This is what we call an RSR pattern, also known as rabbit ears. It goes up, then down, then up, then down again. Whereas the opposite, like the flipped mirror image, happens in V6. This pattern is classic for a right bundle branch block. Let me explain using our analogy. Coming back to the highway then, so if we block this road of the right bundle branch, then we need to rely on electricity coming from the side streets of the left side to get over there instead. But only after it first depolarizes the left side. As ventricular depolarization is slower, the QRS complex is gonna be wider. But let's talk about the V1 changes. It shows this classic rabbit ears pattern, but why is that? So first we get septal depolarization from left to right, as we said earlier. That's like it normally does. So we're gonna see that tiny little R in V1 and the tiny Q wave in V6. Then left ventricular depolarization is gonna happen, which again is sort of like normal, isn't it? So we tend to have that deep S wave in V1 and a high R wave in V6. So far, it's pretty much the same. But it's that last part which is different. Right side of ventricular depolarization. All this electricity has to slowly move over to that right side, and we pick that up on the ECG. It creates this second peak. The signal slowly moves over towards V1 from the left-hand side, which is going to give us this second big wide R wave. We call that R prime, forming an RSR pattern. The opposite is true for V6, so remember those first two components are the same, the slight S wave and the big R wave, but then we got that electricity moving away from V6 slowly so that we get this deep, big, slow S wave. The highest yield mnemonic to know this, which you've probably heard about already, is William versus Marrow. The middle letters tell you if it's the right bundle branch or the left bundle branch which is blocked, whereas the start and end of the word tells you the morphology in V1 versus V6. So for a right bundle branch block, you get an M-type pattern in V1 and a W-type pattern in V6. Let's talk about the causes. For right bundle branch, it can actually be normal in younger people, but it can also be pathological if there's damage to that right side of the heart. Think of pathology which involves the right side of the heart. Right ventricular strain, pulmonary embolisms, cardiomyopathies, and of course, ischemia. Okay, trust me, you're going to remember this for way longer if we test your active recall as we go. So right now, I want you to pause the video and tell me in the comments, what features would you see in V1 versus V6 for a right bundle branch block? Let's move on to the next ECG. Take a look at this one, and I'll give you a few moments to see if you can figure out what's happening. Now, if you're thinking this is a left bundle branch block, you'd be absolutely right. It's pretty much the opposite of what we saw before. Let's come back to our superhighway image. Let's say we're going to block the left-sided highway. That means that unlike normal, depolarization is going to go down that faster right side first, before the traffic then comes up through those back streets up towards the left-hand side. It's going to be slowly moving in this direction. Let's discuss those ECG features. We're going to have that wide QRS because there is this slowing of depolarization in this direction. The V wave looks towards the right side. There's a slow wave of depolarization away from the right side. In V1, we're going to get this R wave for right-sided depolarization, but then that's quickly going to be overshadowed by this mass movement of electricity over to the left side, away from V1, so we get this deep S wave. Again, the opposite is true when it comes to V6, that slow depolarization towards the lead, so you're going to get this broad notched R wave in V6. It's worth noting, when we have this broad wave of depolarization, it doesn't typically change the axis. I'll come back to why that's relevant very soon. Okay, let's recall that mnemonic. This time it isn't Marrow, it's William, and that tells us that it's the left bundle branch which has a V1 change which is more in keeping with a W shape, and a V6 change in keeping with an N shape for William. Interestingly, a left bundle branch block is usually never normal. A sign of a STEMI can be a new left bundle branch block. Here's some causes, but think of things which generally change the shape of that left-hand side, like dilated cardiomyopathy. Now you understand left bundle branch blocks and right bundle branch blocks. But going back to the left side, what if you knock off any of the fascicles here? Well, that's when you get a hemiblock. There's an easy trick to see them on an ECG, so let me tell you so you sound smart when you're reading your ECGs. We'll start with a left anterior fascicular block. Let's say this lane is blocked here. Impulses are going to move down the right bundle and also down the left posterior fascicle first. But if the anterior fascicle is blocked, then we're not going to get depolarization as efficiently in that lateral superior part of the left ventricle. Instead, electricity is going to quickly move down the right bundle branch and the left posterior fascicle, but then it has to slowly make its way up from the posterior fascicle so that it can reach there. This is what it looks like on an ECG. First, have a look at V1 and V6. And notice here that it doesn't typically follow that pattern of a full bundle branch block, so it might be easy to actually miss this if you didn't specifically look for it. When it comes to hemiblocks, the trick is to look at the patterns in these two groups of leads. The first group is the lateral leads, 1 and AVL, whereas the other group is the inferior leads, 2, 3, and AVF. The clue is in the R waves. It may be a hemiblock if it satisfies these two criteria. Firstly, each group has R waves going in the same direction. And secondly, the direction of those R waves are opposite for both groups. In simpler terms, let's say 1 and AVL are both going upwards. If you then look at 2, 3, and AVF and they're both facing downwards, then that's a hemiblock. Recall also that this is in keeping with left axis deviation. There's different ways to do this. The way I find easiest is to look at leads 1 and AVF. And if they're reaching together, it's right-sided, and if they're leaving each other, it's left-sided. There is more nuance, and I'll probably make a video about it. Let me know if you want it in the comments below. Let's come back to a left anterior fasciculus block. Okay, so there's going to be slow depolarization in this direction up towards the left-hand side. The current is moving away from 2, 3 in AVF, so it's going to be negative in those leads, but moving towards 1 in AVL, so it will be positive. This will automatically make a left axis deviation. It's as simple as that. Again, the causes are typically the same as a left bundle branch block. But what if the posterior fascicle is blocked? Then we're going to see the opposite. The electrical impulses are going to go down the left anterior fasciculus and the right bundle branch normally, but to get to the left posterior fascicle, it's going to slowly move over from the left anterior fascicle in this direction. So that way of depolarization is slowly going towards 2, 3, and AVF. So all these leads are going to be positive, whereas leads 1 and AVL are going to be negative as it's moving away. This will give you a right axis deviation. The causes are the same as a right bundle branch block. Okay, let's stop to test your active recall. In the comments below, I want you to tell me the ECG features that you would see in a patient with a left anterior fascicular hemiblock. Now we've got that out of the way, we've done left bundle branch, right bundle branch, and the two hemiblocks. Now we have to think of these compound blocks, where we get two of them together. Just remember though that if we had a right bundle branch and a left bundle branch together, that would actually cause a complete heart block. So any of these further ones, we're thinking of right bundle branch plus another. This is why it's important if you do see a right bundle branch block morphology with that whole marrow thing, and when you're in uroscopies or whatever, is to make sure you're having a look to see if there's the hemiblock pattern or any other changes which you'll see, because that may indicate that there's actually a bio-trifascicular block. And if you say in your exams, I'm looking for features of a bio-trifascicular block, when you spot a right bundle branch, it's going to make you sound pretty good. Let's consider that there are up to 3 branches which we can block. A bifascicular block is when 2 of these are knocked out. It's most commonly a right bundle branch block and a left anterior fascicular block. The ECG is going to combine both of those findings. Remember marrow for the right bundle branch block, the V1 and V6 will have the M and W shape respectively. But it's also going to have that hemiblock feature, specifically in this case, left axis deviation. I want you to try to recall the hemiblock pattern it will have as well. Well, hopefully you were thinking there's going to be a wave of depolarization moving upwards, so 2, 3, and AVF are going to be more negative, whereas AVL and 1 will be positive. What about if all 3 fascicles are affected? Well, that's a trifascicular block. Remember, this is not the same as a complete heart block. The atria and the ventricles can still communicate. It's just slower and manifests as a prolonged PR interval. A trifascicular block is a high risk of progressing to complete heart block, so may need pacing. A trifascicular block is made up of the same features for a bifascicular block, but this time you're adding on one more component, a prolonged PR interval. So to quickly analyze this in an exam setting, is that if you're given an ECG and there's a right bundle branch block, look to see if there's those hemiblock changes. If there are and there's nothing else, that's a bifascicular block. If you look at the PR interval and that's also prolonged, that's a trifascicular block. Let's put this to the test. I'm going to give you 5 ECGs and we're going to go through the answers one at a time after. Pause the video if you need a bit more time. Okay, so take a look at this ECG. I'm going to tell you the answer very shortly. What do you think this is? Okay, so you should be looking at V1 and V6 mainly here. You can see there's this notch pattern, or like a W shape in V1, and an M shape in V6. So hopefully your mind's going straight to left bundle branch block. That's what this is. But what about this ECG? This one's a left bundle branch block again. We can see that W shape in V1 and the M shape in V6. Now let's take a look at this ECG. What do you think's going on here? So if you look at V1 and V6, it looks sort of normal, but I'm asking you what's wrong with it, so please do have a look and see if you can find these hemi-block features. Notice the pattern here. All of these ones are going up, and all of these ones are going down. Therefore, this is a left anterior fascicular block. All right, let's move on to ECG number 4, and I hope you're looking at V1 and V6. Now, if you're thinking right bundle branch block, fantastic. We can see there's the M and W shape in V1 and V6 respectively. But wait a minute, if you look in those hemi-block leads, we can see it's got the same pattern as that previous ECG. Let's quickly look at that PR interval. Is it delayed? No, it's not. So this is a bifascicular block. And lastly, what about this one? Last but not least, if you get this right, you are absolutely smashing it. If you're looking over the hemi-block area, you can see again, it has that same hemi-block area. And lastly, I hope you're looking at a PR interval because this time it is delayed, which makes this a trifascicular block. And that's a wrap. So now you have a systematic way to be able to figure out whether this ECG is showing you a right bundle branch, left bundle branch, hemi-blocks, or the bi or trifasciculars. That's a lot of content which we covered. If you found this useful, please like, comment, and share it with your mates. Don't forget to check out those free pages of the Never Forget study guides in the link in the description, and I'll see you on the next one.